Hello, hello. Welcome, everyone. Welcome on this beautiful Wednesday. I think it's Wednesday everywhere except maybe Australia. I don't know. They're always like a different day, a different time, but they have one of the most beautiful countries, so they can do whatever the heck they want. Please invite me, somebody. Actually, I have a Greek cousin out there. Please invite me. I want to go see Australia. Have you been to Australia, Dr. Davis?
I have. It's beautiful. It's amazing. And I only saw a tiny part of it, so I'd love to go back.
Well, it was funny because when I was deciding where to go last year, I'm Greek and Norwegian, and I really wanted to go to Norway and everything. But Australia was like, it was either Norway or Australia. And the only reason I didn't pick Australia is I'm so nervous about driving on the opposite side of the road.
Yes, and I did do that, and it was terrifying.
When I was in London for a conference, I was speaking at the BDD Foundation's conference. I was sitting in the taxi, and the whole time I thought I was going to die. Because every time I'm like, why is he going that way? Why is he going that way? And I'm like, So welcome from whatever beautiful country, state, province. I don't know if there's any other terms, continent that you're joining us from. We get a lot of international folks since we are live in like the afternoons. I know the other live streams are later, so it's usually the middle of the night. So we welcome people from everywhere. This is the International OCD Foundation, where we are I call it like the one-stop shop for everything OCD and related disorders. Every Wednesday at, forgot my water. At Wednesday noon Eastern, every Wednesday, we have a live stream, Ask the Experts, where we bring on different experts on OCD related topics, psychiatrists, etc., who are going to answer your questions, going to give you some information, education, and resources. So the way that I look at it is I have OCD. That's why I became a therapist. And if I would have been had this service back when I was struggling, this would have been great. I see amazing people in our chat and our comments all the time, just supporting each other, giving each other, just validation and letting people know that they're not alone. So we have a great community here at these live streams. Thank you so much for joining us. Whether this is your 3,000th live stream or your first, we welcome you. So like I said, we're here every Wednesday, 12 Eastern. We're live on multiple platforms, from Twitch to X to Facebook to YouTube and others, LinkedIn. And if you miss some of this live stream, or if you want to send it to someone, you can always go to youtube.com/IOCDF. And if you click live, you'll see all these live streams. You can always share it. We get a lot of people that watch it after. So let's jump in. I always want to remind people, although we do want to help support you, we cannot be a therapist service or a crisis service. I was going to say crisis service. So if you are going through a crisis, if you're really struggling, please make sure that you dial 988, go to 988lifeline.org. You could go to iocdf.org/find-help to find a therapist near you. Emergency room 911, please take care of yourself. We can't be that for you, but we can support you and resources. So as you know, this is the second Tuesday of the month. Every second Tuesday, Wednesday, Dr. Davis, we were talking about we not getting our caffeine. I didn't get my caffeine and it's 9 a.m. So I forgot. I usually have caffeine, these like matcha bottle things, and I ran out. So I needed it. But this is the second Wednesday, rather. So every second Wednesday, we bring on a psychiatrist. We have so many past pre-submitted and live questions on medications. And as you may know, it is out of my scope of practice, even as a licensed mental health professional, to talk about medications and to give advice on that. So we always want to bring on a psychiatrist. We used to not bring them on as frequently, and then the questions would pile up, and now we have one. But we have one of my favorite on, and I'm not just saying that because you're a guest. You can even ask Emilio. I was like, let's get Dr. Davis. I think you're so kick butt. I love your shirt. Love that you're here. How are you doing today?
I'm good. Also, not enough caffeine, but so this could be fun. But I'm excited to be here. Thanks for having me again.
Yes, IOCDF, please get us sponsored by caffeine and have us at our door before live streams. That'd be amazing. Tell us a little bit about yourself. I know we've had you on and we've talked about your bio and stuff, but tell us a little bit about yourself.
Sure. So I'm a psychiatrist and professor at University of Colorado Anschutz in Aurora or Denver, Colorado. And I'm the medical director of our OCD program, as well as our deep brain stimulation program. I recently also was promoted to division chair for the adult division. So I have a lot of administrative as well as clinical responsibilities. I also have OCD myself. So I have lived experience there, which I think helps shape my practice. But yeah, that's a little bit about me. And I love animals. So I have 3 dogs, 3 birds, and a cat.
Oh, nice. I'm a dog person. It's funny. I grew up a cat person and then I became a dog person when I got a dog. Right after my treatment, I went through like a big bout of depression because you think once you get, I have OCD too. And so when you think you're going to be like happy and rainbows and everything after treatment, it was the opposite. Cause now I like woke up and I was like, 24, all my friends had like moved on and traveled the world and were dating people and stuff. And here I was like, I was housebound. So, um, somebody suggested volunteering at an animal shelter, and it's true. You cannot be as depressed around animals. So I worked with the rabbits, the cats, and the dogs. Fell in love with a dog, and then adopted it. And animals are amazing. Um, Quick question, and you could share as much or as little as you want, but there's a lot of us, with lived experience. That's why I became a therapist, because I really was just like, hey, there's not enough of us out there. You were saying it helped shape your practice, and I agree with that. For you, like having OCD and having gone through that, like how do you think it helps? What do you think it helps provide insight, or what do you think it does to help shape who you are as a professor and a clinician?
Yeah, one of the things that I've talked with people about is I think having OCD is almost like speaking a different language, because the way our brains work is different, I think, than people without OCD. And so I think it really helps to be able to, per se, speak the language. I also think it gives me insight into just the amount of shame and embarrassment and kind of just how bad we can feel about ourselves. And so, I think it helps me to kind of know that someone sitting in front of me who's become very good at hiding this may still be feeling all of these things. And that, I know that sometimes OCD makes people not function at all. And sometimes people with OCD can function quite well and hide it and still be suffering a lot. And so I think my experience gives me empathy for that. Yeah.
Yeah, well said. It's funny that you say a different language because, one thing that I'm really, been trying to do more and more as a clinician is I recognize, we focus a lot on subtypes. So people will say, I have harm OCD, or I'll have, hit and run OCD, or I'll have contamination. But I've started to notice, not started, I've noticed this for years, but there's almost like a certain way that everybody with OCD does certain things. Like black and white thinking is a big one. Like often I hear in my clients, and I recognize in myself, it's like, if I can't do this, then I don't want to do it at all. And it's been a lot of work in my own recovery to say, no, if I can't do my full hour and 15-minute workout, I can only do an hour. It makes more sense to go do the hour than just not at all. Or if I go to sit down and do emails, which I hate, my brain is like, you have to do every email. And I'm like, I don't have enough time in the day to do that much. But it's like, okay, just do the important ones and flag the others and do it tomorrow, right? So certain things like that, you start to recognize like our brains work in a certain way. I've also noticed people with OCD, we struggle sometimes to make decisions because our brain is like, but that decision would be better. And then we go to that, but that decision. So there's these certain things that kind of we all stream and relate to, even if we have different subtypes. And I agree, it's almost like a different language.
Yeah, and I think a lot of us with OCD also have trouble sorting out the important details from the unimportant details. And when we're talking or telling a story, we may give way too many details.
Yes.
Um,
Yes, I do that all the time, and it's so funny because my mom, I do a lot of stuff with her in the OCD space and advocacy, and my sister and I talk a lot and I do details a lot, and I think I see that in my clients. And my mom doesn't have OCD, so she's like straight to the point, and it's hard for me to do that. I'm like, but then I don't tell you everything, that. We have to write and send out a lot of emails through OCD SoCal, and I always have to correct them because I'm like, I know how people with OCD will read this and it won't be clear enough. I remember, we used to get so many emails like, but wait, where, what? And we get less because I'm like, this is how I would think if I read
right.
this email. We got to be very explicit, very clear, because people with OCD, if you say like, click the button that says register today and the button says register now, people will email us and say,
Right.
where's the register today?
Right.
It's like, you've got to be clear. So I remember when submitting my license, there was something, it was like that. It was like, use the form, and they said a name, and then the form had almost the same name, but one word. And I was like, I'm not taking the chance. Let me email them. So,
Yep.
how long have you been in practice? How long have you been helping people with OCD altogether?
Gosh, I can't believe it's been this long, but I finished my residency in 2009, so that's what, like 16 years.
Right.
Um, I've specialized in OCD since probably around 2013. So 12, I can't do the math, but 12 years about-ish. Yeah.
If you're just joining us, we will definitely get to questions. I know I already see some questions. We have some pre-submitted, but I always like to just kind of get updates about the field from our guests before jumping into questions. I know you talked about DBS, deep brain stimulation, that you work with. A lot of times I get questions, and I obviously direct them to psychiatrists, but I'm getting more and more questions about TMS, DBS, ketamine, things like that. First, out of curiosity, because those weren't an option when I was doing medication, it was just medication. Why do you see this interest in these other adjunctive kind of psychopharmacological interventions? What do you, when people come to you, like, what is the interest, and what do you usually hear for people that are interested in alternatives to medication?
Yeah, I think there's several reasons. One is that, unfortunately, even though some people with OCD have a good response to medications and therapy, a good percentage of people don't. And so there's still a lot of people left with a lot of severe symptoms and looking for other options. So, those might be people who could be candidates for something more extreme, like deep brain stimulation, which requires a neurosurgical procedure. But then there are other things that are less extreme. For example, TMS, or transcranial magnetic stimulation, where you don't have to have failed as many medications, et cetera. But it's just really a different modality. And if we want to talk more about TMS and getting it covered by insurance or whatnot, we can go there. But that can be one of the challenges, is getting it covered by insurance. And then the same with ketamine. So ketamine is not approved for OCD, but there is research and literature suggesting that it can be helpful. There's a form of ketamine called S-ketamine, or Spravato, which is an intranasal, so you inhale it. It's approved for treatment-resistant depression, not for OCD, but as we all know, a lot of times people with OCD also have depression. And so I've referred many of my patients with OCD for Spravato, or the generic name is S-ketamine treatment. And it has helped both the depression and the OCD to some degree. Not dramatically helped the OCD, but has helped, I'd say, maybe mostly with cognitive rigidity. But yes. And then what's most exciting, I think, and this is really just emerging, so this is not available clinically at all, is something called low intensity focused ultrasound, where they actually use ultrasound waves to target the deeper structures of the brain. So TMS can only get the surface and kind of deep areas of your brain, but low intensity focused ultrasound can go even deeper. And it's being studied in addiction, OCD, pain, depression, many different things. And that would be pretty cool, because that's a non-invasive way of getting deeper that doesn't require brain surgery. But that's, like I said, it's still kind of early research phase.
Yeah, that'd be amazing. I have a cousin. I was down in San Diego on Saturday. I was talking to her mom that has fibromyalgia and pain. So I was like, oh, that'd be great. There's not a lot out there except pills. For some of the things, I know when my OCD was bad, I had health-related OCD. And I think for me, it was hard just to take medication. When people hear things like TMS, DBS, even the ultrasounds that you're just talking about, some people's OCD are just going to say, oh my God, that's going to damage the brain. It's going to change who I am. People also with medications, it's going to change who I am, et cetera. How do you address when people are afraid, this will change me? I know that was my fear. I was like, I'm going to be a different person, et cetera. How do you walk clients through, whether it's medications or the other options you just discussed, to let people know in some form that their fears are unwarranted? Because I think people have a lot of fears.
Yeah, it somewhat depends on what the person's specific fear is, but let's say, for example, someone's worried it's going to cause brain damage or affect their brain negatively. So I usually have a conversation about, well, being chronically depressed and chronically anxious also affects your brain. It increases cortisol. We've shown, at least in mice, that your hippocampus, or the part of your brain that's responsible for memory, shrinks when you're chronically depressed and anxious. And so not treating your OCD actually is also affecting your brain negatively. And so do we know that medications aren't going to affect your brain negatively? Not 100%, but that's part of what treating OCD is about, right? Is accepting that we won't know things 100%. And so, to our best of our knowledge, actually SSRIs, or the medications we use to treat OCD, actually help our brain regenerate and be healthier, and not have cells die off like happens when you're depressed. And so I kind of weigh that there are risks and benefits of both, and that not treating your brain actually is doing something. It's causing damage. And so the longer you wait, the more time there is for you to be in an unhealthy brain state, and the longer it will take to actually get back to or get to a healthy state if medications work. And then I also just lost my train of thought, but I guess another common thing that people talk about or are worried about are side effects. So that is unfortunately common. And I'd say with SSRIs, one of the most common side effects are sexual side effects, which obviously are bothersome to people. And people are often afraid to mention them to their doctors. And I guess what I would say with that is, bring it up to your doctors, because there are sometimes things that can be used to help. And then people also worry about it changing their personality. And what I have to say to that is, I guess, if it changes your personality in a way that you are uncomfortable with, you can stop it. It's not a permanent change. And usually I don't see medications changing people's personality. There are rare instances where people can feel kind of flat and emotionally numb, but you can address that by backing off on the dose. And really, from my experience, it opened up my whole world. So I was diagnosed in medical school, and I went from being barely able to make it through the day, not being able to socialize, feeling like they didn't have any future, to actually medical school felt almost easy because I had space and I could interact with people. And so it felt more like it allowed my personality to come out, whereas before it was just so consumed by OCD.
100%. I was one of those people. I was so nervous to take medication. I actually was not straightforward with both my psychiatrist and my clinic, my clinician that was treating me for OCD. And I did my first 6 months treatment not on medication. I was flushing it down the toilet or throwing it away. And I finally hit a wall and was like, I need, I started to see success in treatment. So I'm like, I need to try this medication. And it was the same thing. It's like, it let me start to think more clearly. The OCD sort of took there's almost like a distance between my thoughts and me, and being able to start to recognize the OCD. The thoughts were less frequent. They were less intense. I was able to start doing the treatment much more expedited, because I was able to say, wow, I'm recognizing a little bit more now that there needs to be a lot of I'm recognizing it as OCD. Before, it just felt like me, or it felt like the world around me. So I always feel like people around me told me, hey, we like you more. You're more yourself now that you're back on, you're on medication. And then I'm always upfront. I stayed on medication, I think 4 to 5 years, and then got off of it, and I'm not on it anymore. I always tell people if I need to, I'll jump right back on it. But yeah, I think if anything, it brought me back to who I really was. The OCD numbed me out. One point you made that's so good. There's one of the books that I always really, enjoyed in undergrad was a book. I think his name's Michael Sapolsky. He's a researcher, but he has a book called Why Zebras Don't Get Ulcers. And the whole book just talks about what chronic stress does to our brain, to our body, to our mind, talks about the hippocampus being affected. And I think we just forget that having OCD is chronic stress, and it may not cause an instant thing. So we're avoiding, medication sounds scary, therapy sounds scary, but it's not doing anything. We know now, we have way more than enough research to say just how it affects our immune system and cortisol levels and everything. So I always hope people are open and willing to try something. And if it doesn't work, you can always get off it or adjust.
Yeah. Yeah.
All right, so let's jump into some questions. The first question we got was at 12:22 p.m. It says for me. So by Kay, it says, I feel like my OCD symptoms have decreased a lot, but my mood swings are worse than my OCD and I feel depressed. Is this common? So what it sounds like with the question is their OCD is decreasing, but now they're noticing some mood swings and some depression getting louder. I'll jump in a little bit, and then I'd love to hear from what you were saying. I mean, I feel like when the OCD went down, other stuff came up. I started noticing I was really depressed because of how much time I lost to the OCD. I was working with a client yesterday, and their OCD has gotten a lot better, but their ADHD has gotten a lot worse because the OCD forced them to kind of zone in and focus. And when they would start something, the OCD said they couldn't stop till it was finished. Now that the OCD is better, they're having a harder time concentrating and stuff like that. I know sometimes clients with PTSD or trauma, once the OCD is gone, that can rise. So do you see this when people are getting better, sometimes other things might lift?
Yeah, unfortunately, some of my patients are like, man, my OCD gets better and then my depression pops up. And then we treat my depression and then I have more space for the OCD. And so, yes, unfortunately, we see this, and it does mean you have to treat both. The other thing I would keep in mind is that, if you're having, it's hard to know exactly what you mean by mood swings, but if it's like you feel great for like months or weeks on end, and then you feel really depressed, the medications we use to treat OCD can bring out bipolar disorder, but that wouldn't be mood swings within a day or mostly feeling depressed. That would be more like you're super hyper happy, talkative, whatever, for like weeks or months, and then you kind of crash into depression for weeks or months, and then you kind of, so if that's what's happening, I would talk to your psychiatrist about it, because you probably still need an SSRI for your OCD, but you might need also, a mood stabilizer or something else. But you know that's not necessarily what is going on. It may just be like Chris and I were saying, that when you treat OCD and it gets better, your brain has more space for something else, unfortunately. And OCD usually doesn't exist by itself. It usually exists with something else like depression or PTSD or generalized anxiety disorder or ADHD or Tourette's.
Yeah. One of the most helpful things in my aftercare is actually when I dealt with some non-OCD stuff that was pretty horrific growing up. And so for me, I ended up seeing a therapist who we didn't talk about the OCD because it was managed. I had complete treatment, but I addressed a lot of the stuff that came up after. So that's something I tell a lot of clients is like, if after the OCD, there's other things that rise to the surface, you may need to see a professional for that. Or, you may want to see someone just in general to talk about the things that were neglected, why the OCD was so dominant.
Yeah, that's a really important point, actually, is that, ERP is the gold standard for treatment of OCD. But that doesn't mean also other types of therapy won't be helpful for other things that you have going on. And so, I think psychodynamic psychotherapy gets a bad rap, because when you try to treat OCD with psychodynamic psychotherapy, and if you don't know what that is, that's basically when you kind of talk about like your relationship with your parents and with the therapist and with other people and how that plays out, and transference and countertransference. If you try to treat OCD with that, you can go down rabbit holes trying to make sense of things that don't make sense. But someone who struggled their whole life and then not known how to form relationships, and then their OCD is better, but they're left, like you said, at the age of 24, trying to figure out what to do, that type of therapy might actually be helpful for the interpersonal relationship stuff, just not for the OCD stuff. So again, trying to get away from the black and white thinking of it has to be only ERP. Yes, probably for OCD, but we know we can add things like ACT and, other types of CBT, but also you can treat other things with different types of therapy.
Yeah, and I don't have any data to back this up, but I really think part of the reason people ask me like why I haven't had like a horrible relapse, not that they want me to, but they're just like, have you ever relapsed? And some of the things I addressed with a clinician, I had a very strained relationship with my dad at the time, but because of my, I hit a very low. I was housebound. I had an attempt. I was hospitalized for a little bit. I had to move in with my dad and my grandma just so I had somebody watching me at all times. But we had a strained relationship, and a lot of that interpersonal stuff with my dad raised. Also, just dealing with my sexual orientation and feeling a lot of shame with that. But I remember like when the OCD was not gone, but like managed, all that came loud. And I think sometimes, at least what I feel is OCD can almost play like a secondary gain. I almost wanted to run back to OCD and be like, this other stuff, I don't want to deal with it. I want to go back to being like, consumed all hours. But I faced those things in therapy and dealt with helpful tools that were very different than OCD. And I felt like, okay, I don't need to run from stuff anymore. And I think I built a confidence in self. And so if you're watching this and, there's other things going on and stuff like that, as you get better, please don't feel like you're alone. I've heard this a lot where people get better and then some stuff rises. And look, for a lot of people, it doesn't, they don't. So I don't want anyone to be scared.
Yeah, well, it's interesting that you say you were able to deal with your sexuality after OCD was treated. And it's the same for me. I wasn't even able to think about that until after I got treatment for OCD, and then I had the space.
Yeah, because it was just one of those things where I was like, every time I would go to want to think that, I mean, I was single, obviously, because I was housebound. I wasn't dating anybody. But, prior to getting really, really sick, I wasn't, in a relationship, a same-sex relationship, because I got so sick at the end of high school. And it just is. And I think one thing people ask me, like, how do you see the field expanding? The treatment side, the behavioral side. And one thing I say is, like, when I was trained, you didn't treat a client like a client. There were a set of OCD symptoms, and you did ERP, you got the Y box down. And then once the Y box was low enough, you sent them on their way. And I think, going back to that question I asked you, like, I think how OCD treatment has changed for me, being somebody with OCD, I'm like, my clients in front of me are way more than just a Y box score, right? And so really kind of treating the whole client. And sometimes that's with me and sometimes it's not. I am very good at referring out when clients have, I was working with a client that was having a lot of struggles as like a first generation for a race that I clearly am not. And I have a really good referral for that. And we got in contact, but they're doing great with the OCD, but they're just saying, like, that treatment was also so healing, and they feel like a complete person and they feel ready to take on their life. So, I think, we're complex. We have a lot of things going on besides OCD.
Right.
There's a question that we got pre-submitted that says, are there any known nutritional deficiencies that can cause OCD or mimic symptoms of OCD?
That's a good question. I don't know about specifically OCD, but there are nutritional deficiencies that can lead to worsening of mental health issues in general. And those are things like B12 deficiency. So B12 is a vitamin that's found in like meats or mostly meat. It's hard for people who are vegetarian to get B12. So if you are vegetarian, you might want to get your B12 checked. That can lead to worsening of depression and anxiety, which can exacerbate OCD. There's also, if your thyroid is off, that's not nutritional deficiency, but that can affect your anxiety and mood. And the other thing I found is that, sometimes people with OCD have what we call orthorexia, where they have to eat a very specific sort of food that they think is healthy. And I've had patients who have a lot of nutritional deficiencies because of the OCD, because they've limited their diet so much. And so that's something else. If you are struggling with feeling like you only need to eat certain foods, you probably want to let your primary care doctor know so they can check you for nutritional deficiencies, because those can not only worsen mental health issues, but they can cause other health problems too. So that was a kind of answer to your question. I think the general answer is not specifically, but generally, yes, there are deficiencies that can worsen your mental health. I know another common one would be vitamin D. We get most of our vitamin D from the sun, but as we've gotten better at using sunscreen and recognizing sun damage stuff, we tend to be low into vitamin D, and that can affect mood and anxiety as well.
Yeah. We don't talk enough, I think, just in this field about how diet is impacted by OCD. Obviously the DSM doesn't recognize orthorexia yet. I wonder where it's going to go. Is it an eating disorder? Is it OCD? I had it, and it wasn't until there was a name for it. One of my first jobs back after treatment was at a gym. And so I got really caught up in like gym culture and eating well. And then it became something where it was like, I found a diet. It was actually from Men's Health magazine. And I would only eat the things in this diet because my brain was like, these things are healthy. These things are safe. I wouldn't eat even like certain salad dressings. I wouldn't eat. I'm like this. But some people with OCD have safe foods and they eat the same food over and over because it's like, oh, nothing's bad happens when I eat these meals. People chronically checking expiration dates or looking at food or sniffing it and thinking it's spoiled or rotten or being afraid they might be allergic to something so they won't try new foods. But that can really, like you were saying, cause a lot of mental health and physical health complexities. So I always think that that's another place to explore. We have a lot of good data on eating disorders, but I don't think OCD and eating has gotten the same attention.
No, not as much. Yeah.
There's a question, and I'm going to add a little part to it because I'm curious as well. But someone said, is there any information on how a mini stroke in the basal ganglia can affect OCD? I had one, and OCD has been so hard since then. The reason I want to add to this question, I know there was a gentleman at a conference once speaking. He played, I think, competitive soccer, and he got a concussion, and OCD really came out pretty intensely. I had a really good friend that had mild OCD in college. He got in a car accident, and his OCD really spiked. He had some head damage as well. Is that something that we see, that if somebody has damage to the basal ganglia, a stroke, a head injury, could that be something that either causes or exacerbates OCD symptoms? Or are we not sure yet in the science?
No, it certainly could. And I'd be curious specifically where in the basal ganglia your stroke was, because there are areas that affect movement, and then there's areas that affect more anxiety and OCD. Just for our audience here, the basal ganglia are like the deeper structures of our brain, and they're what are responsible for kind of like survival and fight or flight, and thought to be hyperconnected to the frontal lobes in OCD. So like you take in information from the frontal lobes and the environment, it goes to your basal ganglia, and then if you don't have OCD, your thalamus kind of filters it and lets you know what you should respond to or not respond to. When you do have OCD, it kind of like bypasses your thalamus and you just like respond. That's an oversimplification, but that kind of gives hopefully people an idea what the basal ganglia is. So certainly having a stroke in that area that would make sense, that would lead to increased OCD symptoms. It could also potentially lead to decreased OCD symptoms, depending on exactly where it was. And so, one of the areas, or the main area that we target in deep brain stimulation, is in the basal ganglia. It's called the ventral capsule ventral striatum. Or we also target something nearby, the bed nucleus of the striae terminalis. But by stimulating that area, we can reduce OCD symptoms. And we don't really know if we're actually activating pathways or if we're inhibiting pathways. I'm going on tangents here, but another way that's not commonly used to treat OCD, but is still used sometimes, is lesioning procedures. So is actually, killing small areas of tissue in the pathway that's thought to be involved in OCD. And so sometimes actually destroying tissue can treat OCD. And so I think this just goes to show how complex our brains are. And it's really hard to predict what a certain injury or a certain lesion could do. But yes, absolutely, that could play a role.
Yeah. I always, if there is a lot of complexities with somebody's like a stroke or other kind of like neurological potential damage or things like that, I always think it's good to get like a full medical workup. I remember in grad school they used to say that all the time, is like, just if there's ever something that feels that it's a little bit different, get a medical workup. So I hope people are getting that if they're having some complexity.
Yeah, and advocate for yourself, because I think often people with OCD and anxiety are taken less seriously because sometimes we have concerns that aren't maybe real. And so it makes it hard for people like doctors to take it seriously. And it is fine and important to advocate for yourself. And if you need, bring a family member or someone who can help you.
Yeah, people get gaslit a lot because if the provider knows you have anxiety, they'll just dismiss it sometimes. So I know for me, like, I learned that real quick. But in fairness, my health OCD was really untreated at a time, and I mean, one of my doctors once was like, I have to move on, because I wouldn't let him leave the room because that's when he questions. But as I got better, I realized, like, hey, I'm gonna not tell people I have anxiety because I don't want it to get dismissed for that. And I know that I have my OCD in check, so I'll know when I'm crossing a line. But I agree with you. Sometimes people have to advocate for themselves. I'll just give a quick answer to this one. This is from Matthew Bannister, who's a good friend of the program. Hi, at 12:04. He says, I have a question. I have a peer client who is currently struggling with POCD. Do you guys know a great online support group to join for POCD? The two that come to mind automatically is Chrissy Hodges, who is a peer support specialist. I know that she runs support groups, and she focuses on what we call like a taboo topic. I also know that NoCD offers some online support groups. One of my clients with POCD is in a group. I know Tracy Ibrahim, who's a good colleague of mine, runs some taboo and specifically support groups for this. So have them check out Chrissy Hodges, have them check out NoCD. I don't know if you know of any other ones. I know the iocdf.org/help can help people find support groups in their area or virtual ones, but those are the two that I know I've sent clients to that want specific. Because I get it, I run support groups, but some in my support groups, clients have this, but some people want to be in a support group only with these taboo thoughts, and it's because a lot of these thoughts are shunned by society, as they, obviously we know why, but people just want to be around others and feel not alone with these kind of thoughts. The next question I want to ask is from Malcolm at 12:05. He says, can you please talk about lamotrigine medication for OCD?
Sure. So lamotrigine is sometimes used what we call off-label for OCD. So it doesn't have FDA approval for OCD, but it can help, usually used as an augmenting agent, which means we add it to an SSRI or a medication that acts on serotonin. lamotrigine is primarily used as a seizure medication, like for epilepsy, but it's also used for bipolar depression. And it works, it's partly works by being a glutamate modulator. Glutamate is an excitatory neurotransmitter in our brain, so it like increases activity, and lamotrigine kind of tones that down. And more recently, we've learned that, you know, OCD not only involves serotonin, but probably also dopamine and probably also glutamate. And so lamotrigine targets that glutamate pathway. And so for some people, it can actually be really help like on top of an SSRI. Other medications in this class that also act on glutamate would be like memantine or Namenda. I use that a lot. And then Topamax, I don't use that very much because it has a lot of side effects, but that one also is a glutamate modulator. Now, everybody's brain is different. I did have one patient where I prescribed lamotrigine and it made her OCD so much worse. And she actually developed tics. And so, you know, keep in mind what works for someone else may not work for you or may make things worse.
Yeah, that's why it's hard sometimes when people are like, what med? My clients will ask me sometimes, like, what medication did you take? That's the one I want to take. And I'm like, oh, don't do that. The reason they picked it for me is I had some close family members, not with OCD, but with depression, that were on Prozac. And they were like, okay, why don't we start with that? Your family members seem to be taking it very well. It's funny. We were just talking about this, but a great comment from Amy at 1207. She said, I watched a session on some medical providers dismissing and ignoring medical concerns of those with mental health conditions. This happens to me, even though I've documented and verified medical. So yeah, medical diagnosis. So like you were saying, it seems to be common. So thanks for sharing that, Amy. Jessica wants to say hi. Jessica Cook from Facebook at 1208 says, hi, Rachel. I'm a Colorado resident too and overcame OCD 10 years ago.
Hi, nice to meet you virtually.
Yes, Team Colorado. A pre-submitted question. Someone said, do we know if one is born with an OCD gene per se, or if it suddenly appears? I didn't have symptoms until I was 16. Was it just dormant until then?
Yeah, so we don't know of a specific OCD gene, but we do know that it is very hereditary. So there definitely probably is a genetic component. And one of the ways we know that is if you have a set of identical twins, anywhere from like, you know, 40 to 68% of those identical twins, both will have OCD. And we call that monozygotic concordance, but it basically means both twins have it. But is it dormant? That's an interesting question. OCD comes out, there's like two peaks. So kind of like 10 or 11 years old, or kind of your 16 would be in that kind of cluster. And then in like early to mid 20s. We don't know why exactly OCD happens in some twins and not the others, because it's clearly not only genetic, because there's like 30% of twins don't get it when their other twin has it. There's just so much we don't understand about genetics and how genetics are impacted, but we do know that environment can definitely impact your DNA. So I don't know that I would call it dormant, but I would just say, you know, as your brain is developing, whatever genes are involved in OCD probably become more important and more involved in your developing brain. And that may be why OCD can get worse around those time periods.
Yeah, it was for me. I mean, we saw small signs for sure, but man, when I hit 16, it was over. Like everything just flooded, you know, and we look back and there was definitely signs. My favorite color is yellow. And I remember for some reason, the color yellow gave me this false sense of safety. And there was this water bottle I wanted because it was yellow and I threw a fit. And it just, I don't know, it was just this kind of like magical thinking OCD when I was younger, and stuff with lining up my cars and things needing to be perfect. I have body dysmorphic disorder. I started showing signs when I was younger, like getting ready in the dark because I didn't like my facial structure and stuff. But man, when I hit 16, it was like a floodgate opened. So it definitely, it'll be interesting as they do more research on the genes. We were talking a little bit earlier, and Ashton agrees at 1211. He says, there are common threads to OCD no matter the theme. I feel like I can always relate to something in somebody's story with OCD. I relate to all my clients, and there's certain subtypes I just never had. And I'm like, oh, dude, I get it. So yes, I agree with that, Ashton. There was a question that says, what are your thoughts on natural supplements that increase serotonin, like 5-HTP, in place of an SSRI?
I will say I've had my patients try them, and I haven't really had people have good luck with it being helpful. Some people have found them helpful as augmenting agents like inositol or N-acetylcysteine, or for depression, I've had SAMe be helpful. I haven't really had it be that helpful for OCD. So in theory, I mean, worth trying, but my clinical experience has been that they're usually not enough by themselves.
Yeah, I'm on a forum for therapists, and somebody was asking about. I guess the only one people said they've seen any kind of movement was NAC, like you're saying, but other than that, like there hasn't been one that people have resoundingly said, "Hey, this has been like a game changer." So. Yeah. Jessica says, I had a severe case of OCD and did DBS. This is at 12:15. It was helpful and contributed to overcoming my battle. Highly recommend it. I am functioning better today than I ever have. That's good to hear, because I think people hear DBS and get scared, because anything that's kind of like that. I mean, because you work directly with DBS, what are some of the things that you've seen in people's recovery?
Well, first of all, Jessica, I'm so glad you were able to access DBS, because it is hard for people to actually access it. There aren't very many places in the United States or in the world that offer it. Not everybody responds, and that can be hard. I did see a comment that said, if I knew DBS was going to help me, I would do it. Again, we don't know that DBS is going to help you. It helps probably about 60 to 75% of people who have it, but that does mean there's a good 25% of people who had brain surgery and it doesn't do anything for their symptoms. But when it does help, it's remarkable. These are people who have had severe symptoms. They've tried many, many medications. They've usually been in residential treatment or at least on IOPs, all sorts of ERP, without relief. And DBS, it doesn't cure OCD for most people, but it can reduce symptoms from like the extreme level on the Y box to the moderate to severe level, which means that people can start to function. One of the things I found, and this relates to what we were talking about earlier, is sometimes DBS takes away so many of the OCD symptoms that people don't know what to do with their life. They're left with this empty life, and it can be really difficult. And so sometimes we found that even though DBS can be remarkable at reducing OCD symptoms, people may not feel that their quality of life improves until years down the road, because they have to now build a life that they haven't had time to build like their peers. Other patients of mine have been able to function. So one of my patients is a physician, and he is public about having OCD and deep brain stimulation. And because he had structure, he was still able to work as a physician. He was just, going to work and not using the restroom for his 30-hour shifts and not eating for his 30-hour shifts because he didn't want to use public restrooms, but he was still an excellent physician. He had that job and social connection. So for his quality of life improved dramatically pretty quickly. So that was kind of a rambling answer, but hopefully that helped.
Yeah, I've only known one client that ever had it, and a client did an IOP with me because they still had a little bit of OCD left. But man, when I saw like what her life, because she had videotaped some of it, and she had gone to some residentials and stuff. I mean, it was like she wasn't sleeping for days at a time because of her compulsion. She did it, I think, in Florida, maybe. I don't remember. This was many years ago where she got it done, but she had kind of met criteria because she had tried residentials and all medications. And when I met her, she just seemed like a mild to moderate case and actually did really well in treatment. But you make such a good point, because I know I felt that way after treatment, just empty. And I think that's why my deep depression kicked in. Was because of exactly what you said. It was like I went from housebound, 16 hours of compulsions, but it wasn't even the physical compulsions. My mind was always racing. And it was almost like suddenly it was like numbed, like in a good way, not numbed. That wasn't the right adjective. It was like quiet. Maybe I'll say that. It was just like very quiet, and I was doing so much better. And what I always tell my clients, because a lot of people feel that same thing, is part of your recovery. It doesn't feel like treatment because it's not ERP, ACT, CBT, etc., but is to rebuild your life, getting back in school. So for me, I volunteered at an animal shelter. I took tennis classes. I took Spanish classes. I got into martial arts. Then I got a job. Then I went to school because I had to fill my calendar because my calendar was empty. I had no friends. I wasn't dating. So I got better. And then I'm like, to do what, So one thing that I didn't do in my recovery that I try to do with clients now is, as their symptoms are going down, starting to step up volunteer work or getting a part-time job or taking a few classes, signing up for something where you're meeting people every week with a shared interest. Because if you have other things to focus on, it's easier to not like have that, like you were saying, that dip where it just feels like everything's empty.
Yeah.
Sadui at 1218 said, I got insomnia after stopping OCD medications. Please let me know how to get sleep. Is that something that's common, that people get insomnia after medications? Or
there can be lots of reasons for insomnia. And so I guess one of the reasons that comes to mind is that depression can cause insomnia, and the medications we use to treat OCD also treat depression. So I would wonder, is that a symptom of depression, the having trouble sleeping, that maybe came back once you stopped medications? Also, there are medications that are somewhat sedating, so they make you sleepy. And so if that was like treating your insomnia, then coming off of it could make it harder to sleep. If you slept just fine before starting medications and then stopping medications, you had trouble sleeping, it may just take some time to get back to your normal kind of sleep schedule. Yeah, it's hard to answer this one without a lot more details, but I would say it's not common in and of itself to get insomnia. But so the second part of the question is, please let me know how to get sleep. I would talk with your psychiatrist or your primary care doctor, because obviously I can't give specific medical advice, but there are some herbal supplements like melatonin that can be helpful and safe for sleep. But there's also some prescription medications that aren't habit forming that can be helpful for sleep too. I mean, sleep is important, and disruption in sleep, we know, does worsen OCD symptoms. And we also know that people with OCD are more likely to have disrupted sleep. So they are very interconnected.
Yeah, and I'm trained in CBTI, which stands for Cognitive Behavioral Therapy for Insomnia. Obviously, I would definitely start with Dr. Davis's recommendation, with starting with psychiatrist or medical. The other thing that I always say is, I have 2 sleep disorders that I didn't know I had, and just thought I had crummy sleep until I did a sleep study, and I did a legit one, right? I guess it's not saying they're not legit, but if you get one where they just come to your house and put a little thing on and you don't find any symptoms, go to one where you can go into, it's actually like, looks kind of like a hotel, but they set you up with all those crazy things. But I was able to identify what sleep disorders I have and get much better sleep now. But CBTI helped me too, just personally learning it about different ways to improve sleep quality. Setting up your room and your house for success, not laying in your bed for hours if you can't sleep, gave me all these different tools. So I really think if you can do both, it can give you some techniques, but the medication I found helps a lot of clients. Spence asks at 1219, when is it advantageous to prescribe an SNRI over an SSRI, or can both safely be prescribed to the same patient?
Yeah, there's really no rhyme or reason. Both can be helpful. SNRIs aren't FDA approved for OCD, but I certainly use them. Sometimes people have less sexual side effects on an SNRI. Sometimes people, so just so people know, SNRI means serotonin norepinephrine reuptake inhibitor. So examples of that would be like Pristiq or desvenlafaxine or Effexor or venlafaxine or Cymbalta or duloxetine. Those would be some common SNRIs. Because it has a norepinephrine component, it can help more with energy and motivation. So that might be a reason to pick it. But at high, we would still aim for high doses, just like we do for an SSRI. And yes, both can be safely prescribed for the same patient. Probably not at the same time, although sometimes at the same time. One thing to watch for with SNRIs is if you have any problems with high blood pressure, it can elevate your blood pressure. So it's important to monitor your blood pressure if you're on an SNRI.
Well said. There's a couple different questions similar. So I'm going to ask the one at 1225 from Rebounce off of YouTube. I'm a straight guy. Whenever someone bends, irrespective of gender, I get groinal response. There was a couple people talking about like groinal response, like feelings after porn, things like that, and feeling guilt and shame. We know that with OCD, the OCD, people, whether it's sexual orientation OCD, POCD, OCD around guilt and shame around sexual thoughts, etc., the hard thing with OCD is that, we start to kind of use like our body sensations, our thoughts, and our feelings as a weapon. So OCD has us feel guilt and shame for having thoughts, but not only just thoughts. It can be intrusive images, it can be impulsive, it can be sensations. And what everybody asking similar questions, what you have to do is link up with a clinician, because remember, prior to doing any kind of exposure with response prevention or cognitive behavioral therapy, there's education involved. And so when I'm working with a client that gets groinal sensations or has, fears because when they were 10 years old, they saw a kid that was 6 and had feelings for them and things like that, a lot of this stuff has to come from education. You have to understand exactly what's happening in your brain, why you're feeling what you're feeling, how you're misreading different sensations, etc., so that OCD can't continue over and over and over to trick you into thinking you're this horrible person when you're not. Now, the mistake people make compulsively is they try to remember things perfectly. They do mental review, they do mental compulsions, reassurance seeking, continuing to kind of try to figure out like, why did I feel this way, etc. With OCD, the more you give it, the more it grows. And that's really what the response prevention is asking you to do. So the E part would be finding different scenarios or situations where you get triggered. And I always like to pick values-based situations, so everyday things that you'd want to do anyways, and then practicing that response prevention. So make sure you guys are getting some support, because I think a lot of times people misread, reassure. You're not going to go into a clinician that's a good clinician and day one they're doing exposures. Like, it sounds like some of the questions on this, people need a little bit of education to understanding how OCD impacts this. Somebody asked, this was a pre-submitted, since the doses of SSRIs are higher for OCD, so typically like people need a higher dose, can you talk about, is there any risk for serotonin syndrome?
This is also an interesting question. So yes, but I have found serotonin syndrome to be somewhat random. So my patients who have gotten it have been like, they get it with a tiny dose of like trazodone, which is a medication used for sleep. I can't say that I've necessarily seen it be more common at the higher doses of an SSRI. It really seems like someone is more susceptible to the actions of serotonin, regardless of dose. That said, there is some literature that suggests higher risks do increase, or higher doses do increase risk. I have a funny little anecdote. So I take 200 milligrams of Zoloft. I donated half my liver. Apparently, when you take out half your liver, that really spikes your SSRI level very quickly. So I got serotonin syndrome, and I was in the hospital for a week, which is normal, but I don't remember my hospitalization because I had serotonin syndrome. Because, I mean, if you think about it, take out half your liver, 200 milligrams kind of goes to 400 milligrams. And yeah.
Oh, I didn't know that.
Yeah. So that was, I guess, a good experience for a psychiatrist to have, is having serotonin syndrome, because now I know what it's like. But
Nathan asked at 1237, what about these names? Y'all need to campaign to get the names like straight out. What I loved in psychology is like anything that was named, it kind of made sense to me, right? Like cognitive bias, right? Like I can kind of figure that out even if I didn't know the term. But the names that these medications get, I always feel embarrassed trying to pronounce some of them. I know like obviously the brand names, but even the generics sometimes kick my butt. So what about troriluzole?
yeah, I don't even know I can say it. Troriluzole. Anyway, it's pending FDA approval, so it's not yet approved. It's another glutamate modulator, so it works on glutamate.
Okay, so it's kind of up and
Yeah,
coming.
there's a related medication called just riluzole that is used. It's off label as well, but some people use that to augment SSRIs as well.
Someone asked, pre-submitted, has there been any studies on negative long-term side effects for SSRI drugs? I've been taking Zoloft for 10 years, but I'm nervous to taper off.
Yes, but the studies haven't really shown much risk of harm. I think there was a study done in like older people, so like older than 65, on long courses of SSRIs had a very, very tiny risk of increased osteoporosis, so low bone density. And so what I would take away from that is not that you should stop your SSRIs. You should just make sure you're good about taking calcium and probably walking and doing weight-bearing exercises. Some people gain weight on SSRIs. It's not a common side effect, but some people do. And so, there are health concerns associated with being overweight. And so that would be, I guess, a long-term, somewhat related effect. Other than that, not a lot of long-term negative effects that we know of, at least, and they've been around for quite a while.
Okay. A couple more because I'm looking at the time, but I wanted to get this off of Twitch. I always like when we have people from Twitch, LinkedIn. That's always exciting. Twitch Cheese Monster says at 12:40, I recently started. Forgot my water. I recently started taking clomipramine after using sertraline for a while. Sertraline improved my symptoms about 20 to 30%. If clomipramine doesn't end up helping as much and I want to get back to sertraline, is there a high chance of tachyphylaxis occurring? I'm worried about this because if it happens, I might never get the improvement I have before.
Yeah. So again, for our audience, tachyphylaxis means just getting kind of used to a medication and it stops working. And it can happen with things like Benadryl. So if you take Benadryl for sleep or diphenhydramine, people develop tachyphylaxis and then you have a hard time getting off of it because it stops working, but then you get rebound insomnia when you stop it. Most people don't have tachyphylaxis on SSRIs. That said, some people do find that if they're on medication for years, at some point it does stop working. I don't know if that is really the medication stopping working or if it's someone's symptoms just getting worse, right? Like we don't really know how to differentiate that. Just going back to sertraline, I wouldn't think that would increase your risk at all. Where I've seen people run into problems is if they take an SSRI, they do really well and they stop it, their OCD gets worse. They take an SSRI again, they do really well, they stop it, their OCD gets worse. There seems to be almost this, what we call kindling effect, is like the more times you get sick, the harder it is to treat. And so I think it's really important to know that if you can stop a medication and stay well, great. But if you stop a medication and keep getting sick, you probably want to, at some point, just stay on the medication because you might get to a point where you've been sick enough times that it is very hard for an SSRI to work at that point.
I know what I see clinically and also in my own experience based on what you were just talking about is there seems to want to be this rush, like the day that somebody is kind of like at that point where they want to be, they want to get off the meds. And I remember, thank goodness, I had Dr. Jamie Fusner as my psychiatrist. And I remember him having that conversation. He's like, let's stick on it for a year of no symptoms. So like once you get to a point, not no symptoms, but once you get to a point where it almost feels like your OCD symptoms are at bay, let's stay on it for a year after that point, just to make sure you don't have to go back on. And that's what I did. And I never had to go back on meds. And what I found, this is just clinically, not research, in sessions, is the people that like get better, but stay on medication for a while don't need to jump back on it. But people, like you were saying, Dr. Davis, the people that get on it, get better, get off of it right away. Symptoms come up, get on it right away. Those one, you know, there seems to be a lot more ups and downs. So I know people don't want to stay on meds, but if you can, I'll answer the next one real quickly, and then I'm going to give you the final word. I just wanted to add this because it's pretty straightforward. So Matthew asked at 12:35, how do doctors differentiate the difference between anxiety and OCD? I want to see a doctor, but I don't want to get dismissed. What I would say is for that, you don't want to see a medical doctor. Obviously, you want to see a provider, whether a master's level licensed provider, a psychologist. But the good thing is that you want to find somebody who specializes in OCD. And the reason I really wanted to end on this question is because a lot of people, unfortunately, will see a general therapist. Dr. Davis was talking about psychotherapy earlier, and they always miss OCD and they consider it generalized anxiety. And there's such a difference in OCD than generalized anxiety disorder. I have people in my family with generalized anxiety disorder. It is so different from what I go through. So just make sure that you see an OCD specialist. And we do a lot of assessment work, a lot of different tests, self-report measures, but also clinical interviews. And I'm able to spot it really quick. So people who are specialized in OCD will definitely be able to identify it and make sure that you get the proper diagnosis. Dr. Davis, thank you so much. Any final thoughts? I always like to leave people with like a thing of hope. It doesn't have to be about medication. It doesn't have to be about anything we talked about, but anything that you're just like hopeful about in this field, or just anything you're excited about or want to leave people with a message.
Well, I guess the message I would want to leave is don't give up. If something doesn't work, that doesn't mean nothing is going to work. And I think, unfortunately, it is more the norm than the exception that we have to try multiple medications or multiple treatments before something will help someone. And that's normal. And it's also normal if you have to take several medications for your OCD to be better. That's not like abnormal, because we don't have medications that really treat everything that needs to be treated. And so my advice is don't give up, keep trying, even if it's frustrating. It is frustrating, but at some point, you may find something that works.
I love that. Let's end on that. Don't give up. Don't give up. Don't give up. We're both proof that you don't want to give up, and you can go on to be successful and live the life that you want to live. Thank you so much. As always, please head over to iocdf.org, especially iocdf.org/find-help. iocdf.org/find-help. If you are not currently getting a provider, please find someone that can help you out. Getting treatment is one of the best things I ever did. I'm sure Dr. Davis would agree. Getting better from OCD is always helpful. As always, we're here every Wednesday at 12 Eastern. Every second Wednesday of the month, we have a psychiatrist on. Thank you to our special guest, Dr. Rachel Davis, who did incredible as always. That's why I always like her back, and I'm going to bug her to come back in the near future. And make sure to head over to iocdf.org. And thank you so much. Remember, OCD sucks. Don't listen to it. That's my less classy answer to take us out. Take care, everyone. Have a great rest of your day. We appreciate you hanging out with us for an hour at this live stream. And thank you for watching it back if you're watching this later on. Take care.
Bye, everyone.
Thank you.